Hi guys, now you can hear me. Thank you for joining us for the ultrasound lecture series today. Today we're going to talk about kidneys and a little bit about renal ultrasound. This is going to be a pretty good topic. But before we get going too far into just talking about it, let's just dive right on in and talk a little bit about kidney ultrasound. So we'll start this again here. So as we get started, think through about, I like to think through about cases, right? Kind of think through a clinical context, kind of set our framework and set our mindset to kind of understand the topic at hand. And so in this context, this is a hypothetically derived 35-year-old gentleman who presents to the ED with right-sided flank pain. Says, hey, look, it started in my back area, kind of up on my side. It's now migrated itself down to the right lower quadrant. This has been going on for 2 days. It's killing me. I can't stand it. I need some relief here. Can you do something about the pain? And by the way, what's going on? Because I'd kind of like to know what's causing me so much trouble, right? So that's kind of the scenario that we're being painted here with our clinical presentation, right? So if you look at some vitals, look, the blood pressure is pretty good, pretty normal looking. Heart rate's maybe a little tachycardic, but we can account for that by the fact that the patient is in pretty bad pain, just writhing on the bed. So a heart rate of about 110 certainly doesn't sound like a ridiculously bad thing. The patient's respiratory rate's about 18. SATs are 99%, so it's not a primarily respiratory problem. And the patient is afebrile, which is also going to be an important thing in this context. So that's our vitals, pretty normal other than the tachycardia. So when we do our physical exam, we see that the patient's in obvious distress. They have normal, heart rate rhythm, lungs sound fine. Really, it's not a factor up in the chest. When we get to the belly, the abdomen's soft. We can discover some tenderness palpation in the right lower quadrant. And if you go back to the flank in the GU exam, they have right CVA tenderness. So you start smacking on that right CVA area, and they say, yep, that's where it hurts. And as any pain that happens below the belly button, the patient should probably get a little bit of a GU, like beneath the pants exam. And so this patient has no specific testicular tenderness to palpation, certainly no swelling or erythema. And we kind of let the cat out of the bag a little bit by saying this is a renal talk, but you can kind of think about it in that context. Like pain from the scrotal area can be referred up to the belly. Pain from the belly can be referred down to the scrotal area. And so it's really important to make sure you don't have some testicular pathology, whether it be a torsion, epididymitis, an orchitis, things like that. Definitely outside of the scope of today's conversation, but something nonetheless that's important to look at on your physical exam. So with this patient's picture in mind, right, we have 2 days of colicky right flank pain. We have tachycardia, otherwise reasonably normal vitals. And then we have this clinical picture, this physical exam showing tenderness in the right lower quadrant and the right flank, but no obvious testicular etiology. What do we think is going on, and what can we do about this, right? So what do we do next as we're taking care of this patient in the emergency department? And kind of ultimately the other big question that's in the back of our mind, what's the diagnosis that this patient is going to ultimately have? And I think, by virtue of the fact that we're talking about the kidneys, we can easily say, oh yeah, this is the kidney that's going to be going, that's the issue, or but certainly what specifies that down into kind of what's going on here. And so the topic of this conversation is called stoned, kind of letting the cat out of the bag further, kidney stones in the context of this patient, right? And by stoned, I'm not talking about some thing that you may smoke or ingest that makes you kind of high. We're talking about something other than that. And obviously we're in Ohio, so we're certainly not talking about marijuana, which I always found interesting. Like, I'm a big Bucks fan, Buckeyes fan, but I find it interesting that our logo looks remarkably similar to some illicit substance here. So anyway, that being said, kind of moving off of that, we're going to be talking about renal ultrasound and kidney stones, really not being stoned in any other capacity. That will be a topic of conversation for some other for some other time, not in this context with ultrasound, right? So today we're going to talk about the role of ultrasound in the management of nephrolithiasis, or kidney stones. And we kind of got started on this conversation years and years ago with a Twitter conversation that I had with the guy who runs EM Lit of Note. And he was basically just pressing in and saying, hey, what's the literature for ultrasound-guided evaluation of kidney stones? And right, there's some good literature that says, hey, look, it's safe to do, right? You don't have this huge missed bad outcome phenomenon. But he was really pressing in, like, can you accurately identify distal stones greater than 5 millimeters? Because when it gets down to it, like, that's really what we want to know. If you have a small little 2 millimeter stone, who really cares? Other than the patient, of course. I mean, it's going to hurt, but we can pain control that. It's going to pass. But we want to know if there's something that we're missing along that whole track that's huge that we need to identify so that we can, either artificially get this out with some procedure, or if we can safely manage the patient just by monitoring them. And so enter in this whole concept of ultrasound. So here's a nice example of a bladder with a UVJ stone on the right with that twinkle artifact kind of emanating from it. And then obviously we're going to use that scan, and then we're going to look kind of up here at the kidneys to see if there's any hydro or lack of hydro and what that means for us, from a clinical significance standpoint. And so this lecture is kind of predicated on a generic understanding of how to scan a kidney, and we're going to talk a little bit more about the literature and the test characteristics of this study, right? And how we get to this diagnosis. So we're really talking about kidney stones, right? So if we want to go talk about demographics, some, just general truisms about kidney stones, it accounts for about a little over 1 million ED visits annually for suspected kidney stones. The lifetime prevalence has a slight predilection towards men, so men tend to get stones a little bit more than women, though it's certainly a common phenomena in both, as we probably can well testify to in our clinical practice. It tends to be in a younger-ish cohort, so in that second to fourth to fifth decade of life, kind of with the peak in your 30s and 40s is kind of when most people get their kidney stones. Interestingly, and I don't know how much of a clinical impact this has, but it has a slightly lower incidence in black people compared to whites, as well as a slightly lower likelihood in lower socioeconomic status. Again, what that means for us clinically, I don't know. I mean, certainly in my context, I see it in all sorts of people, and I'm certainly not going to make medical decisions based on, hey, you are, of this this race or economic status, you likely do or don't have it. I think it's, the statistics are probably marginal at best. But for those of you who are going to practice in the Southeast United States, some sources indicate that there's a slightly higher incidence there as compared to other places. And for what reason, I couldn't tell you, but that is what it is. So what causes kidney stones, right? And we can think about it in really three contexts, right? Either supersaturation of the salts that are in your urine. So you have your calcium, your phosphate, and it's just supersaturated in the urine. And when you have supersaturated salts, they tend to crystallize and precipitate, and you develop stones. And the same phenomena happens in the gallbladder, and you can create the same phenomena in the test tube, right? We've seen those kids experiments where you pour a whole bunch of sugar into some water and put in some little, stimulant thing, and it creates the crystals on that piece of string or whatever. So it's kind of that idea. On the other hand, you have urinary stasis, so you don't have the flow of urine through the ureteral system, and that can precipitate some kidney stones. And then you have this whole lack of inhibition thing. So citrate is a chemical that can inhibit stone formation by complexing with calcium in the urine, and it also inhibits this like spontaneous nucleation and prevents like growth and conglomeration of these crystals. And so if you don't have that, you can then get like stones because of a lack of inhibition. Now, the stones tend to be of multiple types. So you can have the calcium stone being the predominant type. So it's calcium plus oxalate and phosphorus, with the stryvite and the urea stones accounting for a minority subset of all stones. So the stryvite being your bacterial created stones, and the urea, obviously urea crystallizing as opposed to your calcium. Now, what happens to these things? Obviously, you get some degree of obstruction as the thing's attempting to pass, and that creates pain, right? And the pain, and the patient either has a stone that passes or it doesn't, right? If it's small, the thing's going to pass right on through. If it's large, it may get obstructed, causing some further upstream complications, and may need some degree of intervention by a urologist to get that out. And you can kind of correlate that degree of the size, right, and the shape of the stone with the risk of obstruction or passage, right? And so the literature that I've seen basically says if you less than a 4 to 5 millimeter stone, the thing's coming out, right? It's 98% pass rate. If that's in that intermediate range, 5 to 7 millimeters, you got about a 60% pass rate. And if you're greater than 7 millimeters, and I've seen some up to a centimeter, then your pass rate drops down to 40 to even, I think I've seen as low as 20%. And so the way I present this with patients is, hey, look, depending on how big this thing is, it will depend on how likely it's going to come out on its own, right? And so if it's less than 4 millimeters, I'm not worried. We're giving it a trial of passage. If you're greater than a centimeter, the thing's probably not coming out on its own without help, and you're going to need to get help to get that thing out. And somewhere in the middle, you have to risk stratify with the patient and see kind of how likely this thing is to pass, right? And so these get obstructed in a couple different places, or get stuck in a couple different places, and those are typically the ureterovesicular junction, or the UVJ, right, as that ureter attempts to enter into the bladder, right? That's the most common place for the thing to get obstructed or get stuck. And it's followed by the pelvic brim, as that ureter comes over the pelvis, and then the UPJ, or the ureteropelvic junction, as that ureter is coming out of the kidney and kind of forming, and it's narrowing down from the renal pelvis into the ureter. Those are three common places where you get stuck. But as those of you guys who have practiced for any period of time know, I mean, these things can be found in any one of these number of places. But in my experience, have been mostly in that UVJ location is where I found the stones. So that leads us to kind of what do we need to do in the emergency department to work these things up, right? And obviously this conversation will be very different for a urologist, but for us in the ED, what do we need to do? And there's really two things, right? Evaluate, once we've identified the stone, right? Evaluate for stone-related emergencies, right? And rule out clinically important alternate diagnosis. So number one is you have a stone, you found it somewhere, it's probably providing some degree of obstruction, right? It's causing their pain, right? Is that stone that's in situ creating problems for the patient, right? Obstructive related problems. So like I tell people, if you put a dam in a river, you get a lake behind it, right? You also have increased pressures of stuff behind that obstruction. And so is that increased pressure then creating some degree of a problem for the patient? Or on the other token, is that, now that we have that obstruction, some stasis behind it, are you colonizing with some form of bacteria and creating some infection behind that? Both of those are huge problems. We've talked about definitely the infection one in this forum in the past, but those are huge emergencies that we need to really identify. And if they're there, kind of consult our urology folks. And if they're not there, then obviously we can manage clinically and see how the patient does. Number two, right, we got to rule out clinically important alternate diagnosis. So in an ideal world, we just know what the patient's got, right? And you say, oh, this is exactly what the patient has. But we may not have that luxury in the real world. And so what we need to identify in our workup is there something going on that's other than what we think it is? Are we like inappropriately anchoring on this renal stone diagnosis when in reality that's not what's going on and the patient actually has an appendicitis, or more dangerously, like a AAA? So that's kind of the other thought we have to have in the back of our mind. How likely is this a stone, and is there a likelihood that there could be something else really bad going on or worse going on that we need to identify? And those are our two key goals. And so when we look at those key goals, here's kind of from the New England Journal, kind of some of those possible things that could be causing those issues, right? So proximal urinary tract infection, deterioration of renal function due to obstruction, intractable pain, which leads you to have like a bunch of vomiting, that you could like downstream electrolyte problems, or if they have like a solitary or transplanted kidney, like that's really bad. You could have like rejection issues or kidney, failure issues. So those are the emergencies. And then alternate diagnosis, obviously, AAA, cancer, diverticulitis, appendicitis, cholecystitis, bowel obstruction, anything that ends in itis, gonadal torsion, things like that. These are different emergencies that we need to find out are not going on, have tucked in the back of our mind as we're trying to risk stratify what's the likelihood this patient actually has a stone, right? So those are kind of the goals of the ED workup. And we can work that up in one of a couple different ways, right? The first one, and they say 85% of all diagnoses are made clinically, which in my opinion, 85% of all statistics are made up as well. And so in the era of, hi, how you doing? And I have a CT scanner, that number may be adjusted a little bit. But anyway, a lot of where you get to is based on clinical grounds. So, hi, how you doing? What's going on with your pain? Let me push and prod on you and see what hurts as I push, right? Secondly, we can do some labs, and those are certainly important and have varying degrees of importance depending on the disease state you're looking at. But in this context, we want to know, is there infection in that urine? That's kind of the main one. And then imaging, right? We can't see with our eyes inside the patient's body. So we have to use some form of technology to look inside that patient, whether it be an X-ray or CT, or in our context today, ultrasound, right? And we're going to, say that ultrasound is probably going to be the best and first modality that we should use. But, typically, the alternate for us, at least, is CT scan. X-rays are significantly inferior in our context of just making the diagnosis. So those are the ways that we're going to look into diagnosing this patient and managing the patient. as it pertains to renal function, right? If you get an obstruction, right, and it affects the renal function, and again, something you can look at on the labs. The creatinine in these patients are generally normal, right? This is why I don't routinely send a BMP on patients who say I've had 2 days worth of colicky pain, right? It takes multiple weeks for that obstruction to happen to really ding those kidneys to get an elevation in your creatinine. Partly because you have compensation from the other normal kidney, and then partly because it just takes some time to injure a kidney to that degree. And so I don't generally send BMPs, or basic metabolic panels, on these patients to look for kidney function if it's a cut and dry case. Now, if they've had months worth of like flank pain and I discover that they have, some obstructive phenomenon that, could potentially have been going on for that period of time, then yeah, of course, it certainly makes sense to do it in that context. But in the acute context, like the context we have in the patient stem at the beginning here, that certainly doesn't make sense. The lab that may make some more sense for you is looking at the urine, looking number 1 for infection, but also number 2 for hematuria. And I thought the numbers on this were really, really interesting. Hematuria is found in about 85% of patients with renal colic, right? So if you have a stone, better the chances than not that you'll actually have blood in that urine as well. And so the sensitivity specificity numbers are pretty cool. It's got a sensitivity, like blood in the urine for stone has got a sensitivity of about 71 to 95%. So depending on which side of the error bar you fall on, you could say 95 out of 100 patients should have blood. And if you don't have blood, you're in that 5% range, and it's likely you don't have a stone. The specificity certainly is not as great, right? It's 18 to 50% or so. So if you have blood, you can't necessarily say, oh, this is for sure a kidney stone. There's a lot of other things that can put blood in the urine in addition to kidney stones. And so it doesn't really work. The logic doesn't work in reverse. But I think it's pretty safe to say that if you don't have blood in the urine, the likelihood of you having a stone certainly goes down. It doesn't go down to 0, right? You can't just discharge and say it can't be this, or, to completely change your management. But man, if you have colicky pain for a couple days and no blood, you at least have to bring other things onto your differential before you completely close the thing off, because the stone is a lot less likely in that context, given these numbers. So what about imaging, right? So back in the mid-90s-ish, right, when this study is published, the idea of doing a CT scan to evaluate for kidney stones kind of emerged, right? And so this article was published in 1996 in the American Journal of Radiology, and it basically showed that studies that the CT scan had about a 97% sensitivity, a 96% specificity, and an accuracy of 97% when diagnosing renal stones, right? And so this is really good test characteristics. Like say, hey, I got this patient I'm concerned has a renal stone. Let's scan them. I see the stone. Man, this thing's super duper accurate. And so it helps if you really want that diagnostic specificity, okay? And it's a great test from that perspective. Subsequent study in the Journal of Urology in 2011, so about 11 years old now, has basically shown that since that time, there's been a huge increase in the number of CTs that were performed for renal stones. I mean, it makes sense. If you have a highly accurate tool in then-generation scanners, and you now apply that to a bunch of patients, you're going to start getting a lot more of that test to look for that entity in these patients. And it really begs the question, is that appropriate utilization? So here's a graph from that same study that basically showed the rate of stone, like the incidence of stones in that time period from like the early 2000s to, late, 2000 decade, right? So up to 2010 or so. The incidence of stones maybe climbed a little bit, but not a ton. But man, look at that CT incidence or CT scan performance. It went way, way up. And so it makes sense. As you have this technology, you're going to start utilizing it more. As you start getting more confidence in it, you're going to start utilizing it more and more and more. And so this is certainly, a trend that's happened. And I'm sure if we trended that out, to present day, you'd see probably a similar stock market-like appearance to this, this CT graph or incidence. Where the rubber really meets the road and where it starts biting is when you start doing some population dynamics. So you say the American population is, at the time when I wrote this, was about 318 million. I think it's up to 330 million now. So we'll just go with these numbers. 318 million just for the sake of the math, right? 10% incidence of kidney stone basically puts about 31.8 million lifetime cases of renal stone in the United States. And so if we start doing CTs on those, let's say we have 31.8 million lifetime cases of kidney stones. Let's say half of them get CT scans. that puts you at about 15 million CT scans. 15 million Americans will get CT scans for a kidney stone, and we throw some further numbers on that with cost. Basically, 1 million ED visits per year for flank pain, right? 50% get a CT scan. You have about 500,000 CT scans a year, and this is kind of some extrapolated numbers based on some reasonable presumptions with math. And then you do some math on that and say it's about $1,400 per scan. And I wrote this lecture, at least this slide, a handful of years ago. And so with all the inflationary forces at play, that number is probably a little bit different at this point. But also 8 millisieverts of radiation per scan. If we're doing that many scans, we basically have 4 million millisieverts of radiation that we're inflicting upon Americans every year at a cost of about $700 million annually for the evaluation of kidney stones in the United States for Americans here, right? And so it begs the question is this an appropriate utilization of radiation? Because radiation doesn't have its, it does have its downsides, and there's appropriate utilization of healthcare dollars as we apply it to patients, right? And so what we found is over the course of that time period, and this is in the study, that the rate of stone detection was relatively unchanged. The detection of clinically important alternate diagnoses was relatively unchanged, and the rates of hospital admission was relatively unchanged. But we had this significant increase in the number of scans performed, which increased costs and radiation. And so it takes up time, right, valuable time in the ED. It adds cost to the patient's bill and increases their overall lifetime radiation dose. And so really the question that emerges from all of this is there a safe and reliable way to evaluate flank pain, specifically in the ED, but evaluate undifferentiated flank pain, and at the same time spare radiation while continuing, like I said earlier in the statement here, being safe and reliable, right? So is there a safe and reliable way to evaluate flank pain and spare radiation in the ED? And that really brings us to the kind of second part of our conversation here, where we look into some literature and see what we can do with some clinical decision tools and what we can do with some ultrasound to really put a dent in those numbers and come up with kind of a very pragmatic pathway of how we manage these patients in the ED, right? So let's back up a few years, 2014. So Chris Moore and colleagues developed this study. It was a research study they published in the BMJ, and they basically derived and validated, at least internally validated, a clinical prediction rule for kidney stones. And I guess this is a good place to start. We have in that triad of things that we can do to identify the patient, whether it be clinical evaluation, labs, or imaging. It really gets at that initial clinical component to the triad, right? So they basically came up with this derivation and validation study saying, hey, can we identify patients with renal stones based on this prediction rule, and can it be effective, right? And so what they did is a retrospective review, 5 years worth of data. They took patients who got a CT flank or flank pain protocol, so that's how they identified their cohort. They selected their patients out. They excluded people with lack of back pain or flank pain, people with trauma, with infections, fever. They had excluded people with cancer, with other renal disease, previous urological procedures, kind of these people that would muddy the water, for identifying this undifferentiated de novo flank pain type patient. And they did a multivariate analysis. And so they got 5,000 patients initially. They got it down to 1,000 patients, and they did their data abstraction off of those, right? And so they developed this thing called the Stone score, which is a mnemonic for the sex, timing, origin, nausea, and erythrocytes, right? So male or female, how long's the pain been going on? The origin would be is it where in the body is it? And then presence of nausea, and then presence of blood in the urine, right? And with that, they basically gave each of those values numbers, and we'll show them right here. And they developed this scoring system that said a score up to this is low, up to this is moderate, and up to this is high. And so they basically said in this combination, if you have a score of 0 to 5 is low probability. If you had a score of 6 to 9, it's moderate probability. If you have a score above 10, it's high probability that you have a renal stone. And then basically said, okay, what are the test characteristics for these different scoring systems? And so what they found in the derivation model is that most people came in with that moderate risk score. So about 20% of people were, or 15 to 20% of people were in that low risk. About half of the people were in that moderate risk, and the other 30 some odd percent of people were in the high risk category. So when you break that down and look of the low, moderate, and high risk, what's the prevalence of kidney stones, it basically follows that linear trend, right? So in the derivation and the validation models, you had about a 10% rate of stones in the low risk, about a 50% rate in the moderate risk, and about an 80 to 90% rate of stones in the high risk. And so you can definitely see that there is a trend toward higher likelihood of stones in patients who are higher likelihood based on their derived scoring system, right? And you can also look and say, okay, clinically important events, how likely are those to happen as the likelihood of stone increases, right? And so overall, the prevalence of clinically important events was about 3% in the derivation and validation group. And in people who are high risk for stones, it was about, at most about 1.5%, prevalence of clinically important events in that high risk category. And so I think that's helpful. It certainly says if there's a high suspicion of stone clinically, there's a low suspicion of some other important events. And you want to put this graphically, you can basically see that there is definitely a trend towards increased incidence of stones, and that the derivation and the validation group, at least internally, are pretty consistent with one another. So it gives some credence to the validity of this scoring system, in the evaluation of patients with stone. So the next step that needs to be done in this context is then say, okay, fine, that works at Yale where they did the study, right? Does that work elsewhere? Does that work here at MetroHealth, right? And so there was a multi-center study that was performed in 2016 basically saying, can we validate this externally at other sites in multiple institutions? And they basically came up with the findings that, hey, look, when you applied the score, it's better than physician gestalt, right? But maybe not as quite as rosy as the initial study presented, right? So they said there's a sensitivity about 50% or 53% for a high-risk score, and a specificity about 87%. So still it performs decently, but not perfect. And their final conclusion is basically there's not enough sufficient accuracy in this study to defer the CT scan, but it still kind of shows a trend in the right direction, right? So what they did is they did a prospective evaluation, patients with suspected kidney stones. They calculated a stone score. They got a clinical gestalt from the physician, and they scanned the patients, right? And they basically said, here's our clinical gestalt, or here's the stone score, and kind of they measured off the clinical gestalt on this little bracket on the right hand side here, and they ran people through the protocol. And so they found about 40% of people with stones, 5% with alternate diagnosis, and 11% of them were ultimately admitted. And so they found an ROC curve that outperformed physician gestalt for sure. When you evaluate these patients, with a stone score. Here's another example, or another graph from their study, basically showing the prevalence of ureteral stones with low, moderate, and high risk, and the prevalence of alternate diagnosis. So it's still pretty low, still performs in a pretty decently linear fashion. And so in the validation cohort, they found the prevalence of ureteral stones was about 13% in the externally validated cohort, about 30% in the moderate risk, and about 70% in the high risk. And so it follows that trend. It just doesn't follow it as strongly as in the original validation study. And that kind of makes sense, and it tends to happen in validation studies. As for clinically important event rates, there was slightly higher event rate overall. They didn't really specify in the original study, but basically in a high-risk patient, you have about 1.2% risk of clinically important alternate events. Here's the graph from the table, kind of showing the sensitivity and specificity of the stone score at the three different levels based also in gestalt. And so if we strip away some of the extra data, we say, hey, if you're high risk, stone score above 10, your sensitivity is 53%, your specificity is 87. It kind of reverses a little bit. So if you're 5 to 13, your sensitivity is 96%, specificity is 23%, and gestalt somewhere in the middle. And so I don't know, it's kind of mixed data, kind of what do you do with that? They modified it a little bit, took out some other things, and they found some different test characteristics. So basically they said it stratifies patients into high, moderate, and low risks. Specificity or high risk is not sufficient to deter, though there still tends to be kind of this trend towards increased risk for stones and decreased risk for alternate diagnosis. And here's the modified information. So as it gets to the goals of ED Workup, does it help us evaluate for stone-related emergencies? maybe not so much. Does it help us rule out clinically alternate diagnosis? Well, it helps, but maybe not perfect. And basically that takes us where I want to go with the rest of our time here, and that is looking at what's called the Stone Plus score, right? So they basically did the Stone study, right? And they said, well, what if we add ultrasound to that? Does that help us improve our test characteristics in the diagnosis and management of patients with kidney stones, right? And so from a background perspective, they said ultrasound looks for hydronephrosis. It's a little key here we got to remember. But ultrasound looks for hydronephrosis. It's a secondary finding of stones, right? So if you have a stone, theoretically, it's going to cause some obstruction. Theoretically, it's going to cause some dilation in the proximal ureter. And then theoretically, we'll see that as hydronephrosis, right? This is a recognized modality by ACEP, in the evaluation of flank pain, looking for hydro. And hydro itself, the ultrasound itself has a sensitivity about 75 to 87% for hydro and a specificity of 82 to 90 or 89% for hydro. So from that perspective, it performs decently well to evaluate for that specific end. But the question is, can we apply that to stones, right? And so if we kind of back up a little background, generally we grade hydro in 3 levels, right? So left is here mild hydro. So you have some dilation kind of that renal pelvis a little bit. Moderate, you see some more extensive dilation of the pelvis into the calyces, and then severe kind of on that right, where you have severe distension of that renal pelvis, kind of loss of that architecture, and starting to thin out that cortex a little bit, is the progression of hydronephrosis as you kind of see the patient or as you scan the patient. And so the goal of this study was basically saying, adding this plus component, point of care limited ultrasound, right, is to get your medically necessary mnemonic, would that improve the identification of uncomplicated renal stones, right? And so they had this protocol, prospective evaluation, patients with suspected renal colic and receiving a CT scan, got a stone score calculated. They also got the plus component performed, so they got an ultrasound for looking for hydronephrosis, and they compared their outcomes, symptomatic stone and important alternate diagnosis, right? So I had 835 patients, a little over half of them with stones, and about 6% of them with alternate diagnosis. So that's your baseline demographics. And what they found is that the overall performance of the ultrasound, right, for any hydro had 65% sensitivity and 75% specificity. In moderate to severe hydros, 44% sensitivity and 93% specificity for stones, right? And so if we look at it here, this is the graph that shows that sensitivity and specificity, and they break it out with all patients, right? Sensitivity, specificity with the ultrasound, can be the top line of each section, and then with any hydro and with moderate or greater, without ultrasound, the top line, and with any hydro, so mild, moderate, or severe, or if we take that super duper severe, the moderate or greater category, kind of what that is. And so if we take this data, this is a lot of information to just kind of stare at. We can kind of twist our eyes around and look at it and kind of and stare at that. But if we strip away kind of all the extra data and look at what we want to know, the sensitivity for of the Stone Plus for stones, right? In a low to moderate, or basically low probability for stone score plus moderate to severe hydro is about 40% sensitivity and 98% specificity, right? And then you can see the numbers thereafter. So in a moderate category plus moderate to severe hydro, 42 and 92. In a high risk category with moderate to severe hydro is 47 and 78. So the numbers are kind of interesting. They don't necessarily follow that linear correlation, but you can definitely see that the Stone Plus, right, Stone score plus hydronephrosis has a pretty decent specificity. So you see the thing, you see hydro, they got a good Stone score. There's probably going to have a stone in there. Stone score and no hydro, right, still struggles on the sensitivity side. And so here's the graphical representation, low, moderate, and high risk of patients with any hydro, without the ultrasound, and with different degrees of hydronephrosis, right? So the question is, okay, so we know the test characteristics looking for stone. What about urological intervention in the next 90 days, right? Does it help us identify that? Because theoretically, you could say, okay, look, if you don't have any hydronephrosis, you don't have a significant enough stone to make a significant enough obstruction to theoretically cause the urologist to have to pluck anything out, right? Conversely, you could say, man, if I got a lot of hydro, maybe there's a higher risk that I got to send this patient to urology to have them go break up that stone or pull it out or do whatever they need to do to get, or stent past it or to do PerkNef behind it, whatever they need to do to manage this stone, right? And so the incidence of urologic intervention in the next 3 months was basically overall about 30% for everybody. And if you take no hydro, any hydro, and moderate hydro, you start seeing a linear correlation of increasing likelihood that they might need a urological intervention in the next 3 months. And so that's helpful, kind of an interesting piece of data to add to that. And so here you can kind of take the whole graph, as it were, and look at those based on the low, moderate, and high risk with or without hydronephrosis and see what those sensitivities and specificities happen to be. And so, the specificity for urologic intervention in someone with moderate to severe hydro is actually pretty good, especially for some reason in that low risk category. They tend to need that. Prevalence of alternate diseases, it was low, and so I have to look back and see if this, if it met statistical significance in terms of powering, but certainly, when you start adding in hydro, you can just kind of see there's a little bit of a drop off in the number of clinically important alternate events. And so if we look at it from kind of strip away the extra data and look at the important data, all patients, there's about a 6% rate, 6.5% rate of important alternate events. If you add hydro to the mix, it drops that down about 2.5 to 3%. And if you look at low, moderate, and high risk, those are going to do the trends that we've seen, and those trends are going to drop off. So to the point where if you go to the extreme, right, you have a high-risk patient for stones, you have a hydronephrosis identified in scan, your risk of alternate diagnosis is about 1.1%, right? So it's pretty low. And to be perfectly honest, this kind of correlates with that study that was published in the New England Journal, I think it was about 2014, where they're looking to say, does an ultrasound first protocol, is it safe? Like, can you do that without missing significant events? And they said, basically, yeah, you don't miss a significant number of clinically important events with an ultrasound first protocol. And so to summarize this particular study, right, the plus increases the detection of symptomatic stones, right? Maybe not perfect. It's not, as shiny as that CT number of 96 and 97%, but it did increase the detection of symptomatic stones and is most profound in its effects with low, moderate stone probability, which was really, really interesting. So you can make an argument that said, hey, maybe if you miss this clinically, but then you find something in addition to that on your test, it really bumps that back up and brings them up into the category that would be otherwise like a higher risk category if you had other features clinically, right? The plus component also helps predict the need for urological intervention, right? And so that was helpful information. And there's a decreased risk of alternate diagnosis when you find hydro on the plus component of the scan. So, interesting. Maybe not that silver bullet we're all hoping for, that all sonophiles want, but it was really interesting. But there's one glaring limitation of this study that I could think of just right off the top of my head, and that is it only evaluated for the presence of hydronephrosis. Did you guys notice that? So their end diagnosis, or their end goal was to say, do they have hydro, right? Not can you find a stone, right? Now, ultrasound, granted, is not perfectly suited for stone detection, but we all know that if the stone's in the right place, you can see it, right? Most of the time, if it's at the UVJ, I shouldn't say most of the time you can see it, but most of the time that you can see it, it's at the UVJ, right? And so it's not uncommon to scan. They got hydro, you go down to the UVJ, and boom, it's there, right? I've also had plenty of situations in my clinical practice where I see hydro proximally, nothing distally, and I go back up to proximal, I can find the thing in the proximal to mid-ureter. Or the other example where I've had no hydronephrosis, right? They would fail that plus side, but then I go down to the UVJ, and boom, there's a stone there, right? And so what the study doesn't incorporate is that identification of a stone, right? And I think when you really identify that stone, that changes the entire paradigm in terms of what your likelihood of diagnosis is and your likelihood of alternate diagnosis, because now you've found that stone, especially if it fits with the whole clinical picture. So if we back up just a little bit regarding this stone plus study, when we go back to our ED ultrasound or ED workup goals, right? The goals were to, number one, evaluate for stone-related emergencies, right? And so we kind of can do that. No, not perfect, because we still need to get that urinalysis to look for infection, but you can see if there's hydro. And we've talked in other contexts about if there's echogenicity inside that hydro, maybe there's a pyonephrosis. And so to some degree, you can kind of correlate that with stone-related emergency or infectious-related emergencies, but certainly obstruction or mechanical emergencies we can evaluate for. And number two, can we rule out clinically important alternate diagnosis? And I guess rule out is a very nuanced term. But if you have a high risk with a moderate to large hydro, you can get that risk down to about 1%, which is kind of that threshold in my head for we don't worry about it anymore. Like the risk of testing is going to exceed the risk of complication, or the risk of complications is exceeded by the risk of testing in that situation. You're going to have to, by the law of diminishing returns, do a greater number of tests to get that number, that 1% number, a lot further down. So we're kind of getting there with the alternate diagnosis, right? So what do we take home? Like I said, we're going to make this very pragmatic at the end, and kind of how do we deal with this at the bedside, right? And so what are we going to take home? Stone score is useful to risk stratify patients. Try it. Go to the bedside and throw them through the stone score and see where it spits you out, and see how that correlates with your gestalt. And there's probably going to be a few patients where it may increase your risk, your pre-test probability, or I guess now post-test probability, of renal stones. The next take-home point is add ultrasound first, right? It's a low-cost, low radiation or no radiation modality that you can do to evaluate the patient. And in the right context, you can get that specificity high enough and the risk of alternate diagnosis down low enough that certain patients you may be able to stop there, right? Even if you don't see a stone. Thirdly, for high-risk alternate diagnosis where you just can't rule it out, you still probably got to get the CT scan. But hopefully, if we do our job right, if we do ultrasound first, we can decrease the denominator of CT scans that are being performed, right? And greater hydro should basically prompt greater more urgent urologic follow-up, right? And I don't necessarily have a number and say if your hydro is severe, it necessitates this, and if it's moderate, it necessitates this. But it just should be that marker that there is that relatively linear trend between the degree of hydronephrosis and the degree of urological intervention in the next 90 days, right? So they came up with a protocol, right? And I love all these graphs because it's just more you got to memorize. But they basically broke it down to low, moderate, and high risk, and kind of what their recommendations were based on that. I think if we kind of be really, really practical based on experience here and kind of how we utilize this, and what's a very pragmatic approach is basically say, okay, you got the patient with flank pain, right? They're in the right cohort, so in their second, third, or fourth decade of life, maybe approaching the fifth decade of life. Ultrasound them, right? See what you find. You're going to find one of four things. You're going to find that the scan is totally normal from a hydro or stone perspective, right? I'm obviously ignoring all the cysts and masses and all things that could happen there. But from a hydro or stone standpoint, it could be perfectly normal, right? And if you have colicky pain, right, with a normal CT scan, you're probably just going to have to bite the bullet and CT the patient, right? And this is kind of the way I do it. If I have let's say, this 35-year-old gentleman, right, who comes in with like really, really bad pain, and they have a ultrasound that's normal that shows no hydro and no renal stone, I'm more likely to CT scan them to, number one, either confirm my diagnosis, my clinical diagnosis of stone, or say, okay, maybe I'm all wrong and I got to find something else and just kind of, bite that one and just figure out what's going on with this patient, right? So that's kind of option number one. Option number two is they could just have hydro, right? You scan them, there's hydro, that's all you find, right? So now what do you do with that? Well, that requires a degree of clinical correlation. So I kind of put people on the age spectrum. If you're younger, my risk of having severe badness, right, that I need to CT scan for is lower than if they're older, right? As age increases, the number of bad things that can happen in the belly increases, right? And so if I have a 25-year-old who's got right-sided flank pain and they have right-sided hydro and they got blood in their urine and the story seems to fit, I'm probably going to be more or less done and follow them up compared with someone who may be older, or maybe they have left-sided flank pain but right-sided hydro. I have a lot more explaining to do, either in terms of what's causing the initial pain or why do they have hydro on the opposite side, things like that. And so they're probably going to get a CT scan. So there's going to be some clinical correlation that's going to have to be provided in that context. So that's option number two. Option number three is you find a stone, just an isolated stone, right? In this situation, if it fits the clinical context, they have got right lower quadrant pain and you find a right UVJ stone. Occam's razor, what's the law of parsimony, basically says that's probably the unifying diagnosis, and I think we're good to go, right? Option number four is basically stone plus hydro, right? So if you have a stone, if you have hydronephrosis, like on the right, you have a right UVJ stone, they got right colicky pain, everything seems to fit, they got blood in their urine, I think we're done, right? You kind of have your diagnosis there, especially since you can measure that stone and risk stratify how likely this thing is to pass. And so age becomes less of a factor when I see stone, especially if it fits with the patient's clinical presentation, versus if I don't see that stone, then I have to kind of age stratify, risk stratify, and decide what further imaging needs to be done to kind of evaluate this patient. So that's kind of my pragmatic approach to this. It's certainly not what I've discovered in the course of kind of looking into this and practicing, is that the ultrasound, it's tough to say as a sonophile, is not the perfect test, but I think when applied with an eye towards some evidence-based as well as some pragmatism, it can be a very helpful test and won't completely obviate the need for a CT scan, but it will certainly decrease that need in a select cohort of patients. So with that being said, that's kind of the extent of what I've prepared to talk about today. I guess I'll open up the floor for questions. I know we have some of our ultrasound experts on this call as well, and so I definitely would welcome some input from Sandy, Diane, kind of other people who may want to weigh in on this one. But any questions, comments, concerns, things like that?